Our topic for this lecture is neurologic pathophysiologies, and we'll start off with some introductory comments and then focus specifically on stroke. So on the stroke piece, we are going to specifically compare and contrast both the etiologies as well as the manifestations of stroke. So as we think about some of the overall concepts, when we think about neuropathologies, there are some things that we've already talked about that we want to assure that we revisit. One of those pieces is atherosclerosis and thrombus formation. This is especially important when we talk about stroke and the evolution of stroke. We know that atherosclerosis is a significant risk factor for the development of stroke, as well as thrombus formation, either as a result of the atherosclerosis or an embolic phenomenon. Inflammation and infection are also important. In one of our lectures, we'll talk about meningitis versus encephalitis, so that idea of inflammation and infection becomes very important. We also, though, need to think about neurotransmitters, and we have to think about whether or not those neurotransmitters are dysfunctional. Is it because the neurotransmitters are insufficient, or are they not being taken up? Could this be a receptor function issue? Is the receptor faulty, or is the receptor unable to respond to the neurotransmitter? And then we also have to think about the sometimes feels somewhat convoluted, but the basic anatomy is, when we think about neurotransmitters, this has to occur at the synapse, or could it be at the myoneural junction, that junction between the muscle and the nervous system. Additional concepts that are important are the integrity of myelin and the myelin sheath. Remember that the nerves are covered by myelin, and so when that myelin sheath is patchy, or when it has breaks in it, then the transmission of the impulses along that sheath would also be patchy or interrupted. And then we'll also think about trauma, especially in the brain, but we also think a bit about spinal cord. We're going to focus more on brain trauma. The other piece that we want to have a good understanding of is, as with many of the things that we've talked about, most of the neuropathologies that we're going to talk about cross age ranges. So stroke, infection, seizures occur across all age ranges. Now, when we talk about dementia, Parkinson's, those kinds of things, some of those altered mentation levels, we think more about elders. However, some of the other pieces, as I said, stroke, infection, seizures, cross all age ranges. So we need to be aware of that regardless of the age of our practice population. Before we launch into talking about some of the specifics of stroke, we need to remember that the brain needs a constant supply of glucose and oxygen because of the very, very heavy metabolic demands of that brain. It's estimated that about 25% of the total requirements of our organism, that for our requirements for glucose and O2, have to go to the brain. The brain cannot store energy, neither can it convert other forms of energy for its needs. So that's why it needs glucose as well as oxygen. Now remember our pathway. Glucose is needed to make ATP, and so that's what we need for neuron transmission as well as conduction. If ATP is decreased, then conduction decreases. If that conduction decreases, therefore, we're going to see changes in speech, behavior, memory, judgment, even personality. As the ATP production continues to decrease, we will further compromise neuron metabolism as well as the mitochondrial function, and the mitochondria will eventually begin to die. Remember, dead brain cells don't come back to life. Brain cells can't regenerate. It's important to remember that without circulation, the store of oxygen is gone within about 10 seconds. So what that means is within about 10 seconds of not having O2 going to the brain, those brain cells are going to shift to anaerobic metabolism. Any ATP stores that the brain might have been able to keep within the mitochondria are gone, totally gone within 5 to 7 minutes. And we know that anaerobic metabolism is not the efficient way of producing energy. Without oxygen, we will generally lose conscious awareness within 30 seconds. So think about that importance of O2 and the importance of a glucose supply to our brain cells as we talk about pathologies. Let's take a look then at stroke. Now, stroke, even though that's still our common term, there are, in some circles, especially in neuro, we're kind of trying to change our terminology to call this a brain attack. And I think part of that is to help all of us understand the critical nature of what happens during stroke. We've gotten so used to focusing on heart attack, and the thinking was that if we start calling a stroke a brain attack, that maybe the level of significance and the serious might be better communicated. Now, we've known about stroke pretty much forever, and it was actually described by Hippocrates. When it was described by Hippocrates, he used the Greek term apoplexy. And the Greek term apoplexy actually means struck down by violence or paralysis. And when Hippocrates described this apoplexy, which we've come to understand as stroke, this is the way he described it. Persons in good health are straightway laid down speechless. This is a rather musical way of thinking about what happens in stroke, but it's that idea of someone in good health who is straightway laid down speechless. That suddenness of what happens with a stroke. We know that it was stroke, so it was sort of, I just thought that was a fun way of looking at some of the history of stroke. We know that at its core, as a heart attack, a brain attack means that the blood supply to an area of the brain is unable to meet the metabolic demands of that brain tissue. We know then that the area of the stroke has a corresponding neurologic deficit. So when we think about stroke, we have to think about a lot of different levels. We have to think about the vessels. We have to think about the area of the brain. So we have to think about the lobe. And we also have to think about which side of the brain may be affected. So let's go through all three of those and talk about some of the commonalities or common areas. So when we think about the most common vessels that are affected by stroke, the most commonly affected vessels are the middle cerebral artery, the posterior cerebral artery, and the vertebral artery. The middle cerebral artery primarily supplies the parietal and the temporal lobe. Now, the deficit was going to depend on the branch that's involved. So, for example, if it's the right middle cerebral artery, we would have visual, sensory neglect on the left side of the body. Remember that contralateral effect. The posterior cerebral artery is very important in the temporal as well as the occipital lobes and the upper brainstem. As a result, then, when we have a posterior cerebral artery stroke, we look for defects in vision and depth perception. With the vertebral artery, we're looking at the posterior occipital lobe and the cerebellum. So when we think about those functions, which would be the vertebral artery, we think about swallow. We think about speech, pain, temperature. Vertebral artery stroke may manifest with muscle weakness, gait alterations, balance issues. So when we think about vessels, we have to think about the part of the brain that is supplied by those vessels. And we talked about the three most common. But those vessels supply specific parts of the brain. So now we have to think about lobes as well as we have to think about other parts of the brain. So we have four primary lobes that we think about: the frontal, temporal, parietal, and occipital. As we know, the cerebellum and the brainstem don't have lobes. But remember, when you have lobes, you have one on each side. So when we think about the frontal lobe, one of the important things about that frontal lobe is to remember that most of the dopamine sensitive neurons are in the frontal lobe. And we know that that's important for reward and attention. So when we think about the frontal lobes, the frontal lobes, we think about problem solving, issues. I'm sorry. Let me start over. If that area is affected, we would see problems with problem solving. You might see someone with perseveration, which is something when they keep saying the same thing over and over and over. They may have expressive aphasia, personality changes, which may include impulsive behavior. So when we think about them, that remember we talked about them having dopamine sensitive neurons, and that's where most of those are. This helps us understand the high incidence of depression following stroke that affects this area. In the temporal lobe, the kinds of deficits you might see include receptive aphasia, the ability to recognize faces, deficits with short-term memory. Now this becomes important because if you cannot form a short-term memory, you cannot form a long-term memory. As a result, then you're going to see issues with learning. And we may also see a deficit that presents as aggressive behavior. Now let's talk a little bit about aphasia. Aphasia is sort of a very global term, and aphasia very globally means impaired language. We also talk about dysphagia, and frequently we use aphasia and dysphagia interchangeably, and I have a tendency to do that as well. But aphasia means there is a lack of language. Dysphagia means there is difficulty with language. So that's the pure definition that we should be aware of, and I will apologize already because I tend to kind of use them interchangeably, and you'll hear me do that. When we think about the parietal lobe, then we think about a deficit that affects stroke that affects the parietal lobe. The deficits we would be looking for would include object naming. They may have difficulty with right and left. They may have right versus left neglect. They may confuse right and left side. They may also manifest difficulties with the tactile senses, because what happens in that parietal lobe is the ability to integrate sensory information as well as process our language. In the occipital mode, we think specifically about visual field and color identification deficits, and you may see something called word blindness. Now, word blindness means that even though they have vision, their visual processing is off. So even though they can see the word just fine, the ability to process what that word means is impaired. So those are the 4 lobes. Now we look at other parts of the brain. We look at the cerebellum and we look at the brainstem, and those don't have lobes. So with the cerebellum, if we see a deficit in the cerebellum, we are more likely to see concerns with gross as well as fine motor movement. We're going to see issues with posture. You may see tremor. You may see speech difficulties again, but now it isn't because we can't process it. It's because of the motor control and the ability to actually produce the speech. So it's the motor control of speech. And we also have difficulty with motor learning. So tying our shoes, feeding ourselves, things of that nature. In the brainstem, frequently we talk about the brainstem being our primitive brain. And in our brainstem, we know that this is where a lot of our temperature regulation has to occur, our heart rate, our respiratory rate, the swallow mechanism, and balance. So when you see someone who has a brainstem infarct or a brainstem stroke, you would be very concerned about the ability to swallow. Now remember, with cerebellum, they may have some issues with motor control as well, but you worry about that balance as well. There's another thing that the brainstem does that's very important, and that is produce some of our neurotransmitters. And this is an additional slide that I have posted for you. So when we think about this, the three neurotransmitters that come from the brainstem, we think about norepinephrine, dopamine, and serotonin. So norepinephrine, and you don't see that on this slide, but I wanted to remind us of that. Norepinephrine is important in the mediation of arousal. So again, think about individuals that you worked with who have a brainstem deficit. You have difficulty with their conscious arousal or the ability to arouse. The two that I've included here, because we think about them so much in neuropsych disorders, include dopamine and serotonin. So let's look at dopamine first. We know that dopamine is produced by the substantia nigra, and you can see that here in this little blue area. We know that that the dopamine is important in providing essentially the flow of sensory information back into the cortex, and you can see that on the slide. So, but we need dopamine for our reward functions. Remember, reward, that's where in the temporal, remember in that frontal lobe, which you can see here, we had a lot of dopamine sensitive neurons in that frontal lobe, or in that frontal cortex. And so we need that flow of sensory information coming back to the cortex. So we know that this is where we have our reward and motivation areas, the issues of pleasure or euphoria, but also motor function, compulsion, and we talked about the perseveration. Serotonin is also produced by the brainstem. Now, actually only a small amount of our serotonin is produced by the raphe nuclei of the brain. Most of the serotonin that we produce actually comes from the enterochromaffin cells in the GI tract, and they are there to regulate our intestinal movement. But serotonin is also made in the raphe nucleus, as you can see here, in the central part of the brainstem. What we use serotonin for are the issues of mood, memory, sleep, cognition. So those become very, very important. Now, as a side, just because of the time of year it is, think about when we think about serotonin that's made in the enterochromaffin cells in the GI tract is actually made from tryptophan, which is a protein. That helps you understand why if you eat a big, heavy protein meal, you get sleepy afterwards because of all this serotonin. Remember this issue of sleep. Now remember, we also, when we think about stroke, we have to think about the two sides of the brain as well. So we think about the left hemisphere versus the right hemisphere. And remember that when you have a stroke in an area of the brain, there is contralateral damage. So if someone has a left hemisphere stroke, they will demonstrate right-sided hemiplegia, usually have difficulties with language, and this is where it breaks down to both expressive as well as receptive dysphagia. Now you can also have aphasia as well here. Remember that dysphagia and aphasia is the impaired comprehension or production of language. So as a result then, when you have someone who has a dysphagia, it affects both the verbal as well as the written language because the issue is a deficit in processing the information. In a left hemisphere stroke, you will usually see, once again, keeping with that idea of what's happening on the right side of the brain, a right visual field cut. And frequently someone who's had a left hemisphere stroke will have very slow, deliberate, but potentially disorganized action. Compare that then with the right hemisphere stroke. With the right hemisphere stroke, you're going to see left-sided hemiplegia, and language is usually not affected. You would see the left visual field deficit, and rather than having very slow, deliberate, or disorganized behaviors, you're much more likely to see someone demonstrate impulsive behaviors, be highly distractible. Also very interesting, Interestingly, someone with a right hemisphere stroke is more likely to be unaware of their deficits. Someone with a left hemisphere stroke frequently is aware of the deficits that they have. So let's talk about some very specific types of stroke and events that happen with altered circulation. First thing we'll talk about is a transient ischemic event. Now, this used to be called a TIA, or a transient ischemic attack. Now, this is one time we're starting to call it an event because, again, trying to clarify some of the terminology. So with a transient ischemic event, you will have the individual has a sudden neurologic deficit, and the most common deficits that occur with a TIE or the old TIA is unilateral weakness and lung paresthesia. And what's important about this transient event is that it reverses quickly, and by quickly we mean in less than 60 minutes. That's why this is so easy to brush off. If you image the brain, there is no evidence of infarct, and that's important. However, we know that it's critical that these individuals, that someone who has a transient ischemic event, even though it goes away, it needs to be evaluated because there's a very high stroke risk with transient events. The highest risk of stroke is within 48 hours of the event itself. However, up to 60% of individuals who have a transient event have a stroke within 3 months. That's critically important. Oh, I'm sorry, the 3 months didn't stay on there. I think it's on your first copy, but I'll make sure that that goes back on there. So it's within 3 months because that's important. What also we need to do with the transient ischemic event, because so many of these are due to atherosclerosis, is what we want to do is rule out carotid artery disease. As a result, then, not only should this individual have brain imaging done within 24 hours, they should also have the carotid arteries evaluated for the presence of atheroma and plaque formation. And because if they have a significant stenosis, which is usually greater than a 70% stenosis, they may be a surgical candidate so that they don't have a stroke in the future. A second second pathology is a reversible ischemic neurologic deficit, or RIND. Now, this terminology we're kind of starting to get away from it, but you will still see it in the literature. This also is a sudden deficit, but look at the reversal time. The reversal time is greater or equal to 24 hours as opposed to the transient ischemic event, which reversed in less than 60 minutes. So this is a neurologic deficit that hangs around longer, but it does go away. Again, this is an individual that they may have some unilateral weakness, they may have some paresthesia, they may have some circumoral changes or some changes in the movement of their face, but because it's not severe, they may pass it off, and because it went away, they don't worry about it and they don't seek help. Potentially dangerous. The last pathology before we talk about specific stroke is a lacunar stroke. With a lacunar stroke, this is a stroke in which the deficits tend to progress over 24 to 36 hours. So they start with a neurologic deficit that continues to worsen and get worse over that 24 to 36 hours. This is an ischemic process and is primarily due to hypertension. And this specifically affects the small lesions in the penetrating arterioles of the brain. And that makes sense, doesn't it? It's an ischemic process, primarily due to hypertension. And what's the biggest pathology that we know about hypertension? Yeah, atherosclerosis. Well, where does atherosclerosis especially like to be prevalent? Small vessels. So you've got the penetrating arterioles. Generally, a lacunar stroke will present with motor and sensory deficits. So you'll see a motor hemiplegia. Remember, it's something that gets worse over time. There may be a hemisensory deficit, so they may have numbness, tingling, or difficulty moving a limb. They may present with dysarthria, so they have difficulty speaking, so their speech is impaired. And they may also have difficulty walking, so they may have an ataxic or an abnormal gait. Lacunar strokes are especially highly linked to vascular dementia. So this is a dementia that is actually caused by atherosclerotic processes within the penetrating arterioles. So when we think about stroke in general, we talked about this whole thing about atherosclerosis and all of those other pieces. So we really do have to think about risk factors that lead to the pathophysiologies of stroke. Well, we know that tobacco smoking and excessive alcohol ingestion and drug abuse are all three big risks. In women, the risks include pregnancy and taking birth control pills because of exogenous insulin. And across the board, anyone with a sedentary lifestyle or a diet that is very high in saturated fats, then leading to hyperlipidemia and elevated lipid levels, is at an increased risk. The coexisting pathologies, and we talked about a lot of these, include hypertension, diabetes, both type 1 and type 2, elevated lipid levels, especially the LDL and triglycerides, and obesity. We know that the incidence of stroke is highest in men. However, stroke death is actually higher in women. We also have identified that the rates of stroke is increasing in younger adults. Frequently when we think about stroke being a pathology of elders. Now, remember, we talked about stroke in sickle cell anemia or in sickle cell disease. So we want to be aware of that as a pathology in children that have sickle cell disease because they are at a high risk of stroke. However, looking at young adults in general, we're noticing an increase in stroke rates, especially in males between the ages of 18 and 44 years. Between the years of 2003 to 2012, in that age range in men, the risk of stroke actually doubled. Now, why has that happened? Well, the thought is that one of the reasons that in younger adults, and especially in men in this age range, the reason the incidence of stroke has doubled so badly is because of the prevalence of those risk factors that we talked about. Hypertension, hyperlipidemia, diabetes, tobacco use, and obesity. So we know that this is increasing not only in men, we're especially concerned about men, but it's also occurring in women. So we want to decrease those risk factors as much as possible. When we think about overall stroke, there are two very large categories of stroke pathology. So we're going to talk about these large categories. We've got the background now, so let's look more closely at some specifics. The two large categories of stroke pathology are ischemic stroke and hemorrhagic stroke. Let's start with ischemic. 80% of the strokes that occur are ischemic, so this is the vast majority. When we think about ischemic strokes, we want there's an organizing framework that might be helpful as we think about the effects of an ischemic stroke, and these are the 5 P's: the parenchyma, pipes, perfusion, penumbra, and then we want to prevent complications. So let's look at the first 4 especially because the complications are things that you'll talk more about in your therapeutic management disorders. So when we think about the parenchyma, we're thinking about the functional tissue of the brain itself. We care about the glial as well as the nerve cells. So what we want to do is assure that when we treat an ischemic stroke, we want to preserve the ability of that functional tissue. We think about the pipes. The pipes obviously are going to be the vessels themselves. We have got to restore blood flow through those vessels. Perfusion is the ability to get once we restore flow, making sure that we are actually perfusing that parenchyma, that functional tissue. Now, there are a couple of things that we want to be very careful about with this perfusion, and that is when we think about ischemic stroke, it's very important that we avoid hypotension following an ischemic stroke because we want to avoid that anaerobic metabolism. Remember, we talked about the importance of oxygen getting to those brain cells. So we have to avoid the hypotension in an ischemic stroke, therefore avoiding anaerobic metabolism. The penumbra is an especially important concept. The penumbra is the area immediately surrounding that ischemic event or that ischemic area. We know that after the event, blood flow as well as oxygen is decreased to the area surrounding the event, leading to hypoxia. We also know that that surrounding tissue remains viable for several hours because of the development of collateral circulation. This area is salvageable. However, the extent and the size of viability will decrease over time, so we've got to get oxygen to the area to limit cell death. If we aren't able to salvage that potentially salvageable area, the area does infarct, and that leads to cell death. One of the other things that we want to be important, is important in dealing with the penumbra, is to avoid hypoglycemia. Remember, we talked about the fact that the brain cells don't store glucose, therefore they need a constant supply of glucose. So we need to control glucose metabolism. As a result, we don't want someone to become hypoglycemic, and frequently we will allow a permissive hyperglycemia, even as high as 200 milligrams per deciliter, so that there's plenty of glucose for that brain to metabolize. So we want to control that metabolism. One of the things that we've also used therapeutically in stroke to sort of slow down metabolism is therapeutic cooling. And we actually cool the brain down to 34 to 35 degrees centigrade to slow down that metabolism, therefore trying to extend that area of the penumbra that could be salvageable to give us a little bit more time to restore the flow, to restore perfusion, and get back to limiting that hypoxia. When we think some of the general areas, you've probably heard that especially if you work in a stroke area, when you see the manifestations of an ischemic stroke, you think about FAST: face, arm, speech, and of course time. Do they have facial changes? Do they have arm weakness? Can they speak? Is their speech disordered? And of course, how long has it been? We know that the first 3 hours is absolutely critical because time is brain. So there are two primary categories within ischemic stroke: thrombotic and cardioembolic. So a thrombotic ischemic stroke, we're talking about usually due to an atherosclerotic process frequently related to hypertension and diabetes. So with a thrombotic stroke, we're talking about the vessels inside the brain. The thrombus, the clot, has occurred, or this atherosclerotic thrombosis, related thrombus, has occurred in a vessel inside the brain, and that's where the clot came from. In a thrombotic stroke, the deficit tends to progress over time, so it sort of evolves over time. Because because remember, we're talking about a thrombus from an atherosclerotic plaque within a vessel. It's usually a large vessel, because remember, if it was very small or a penetrating, that would be a lacunar stroke. Compare that with a cardioembolic stroke. With a cardioembolic stroke, frequently the underlying pathology is either atrial fib or there's a clot from a mechanical valve going to the brain. As a result, then, in a cardioembolic stroke, the thrombi form outside the brain and travel to the brain. So this is a critical difference in ischemic stroke, isn't it? The thrombotic stroke The thrombus forms inside a vessel of the brain, as opposed to cardioembolic, the thrombus formed outside the brain and traveled to the brain. That's why AFib and the mechanical valve is where you see the underlying pathology. Because this thrombus formed outside the brain and then traveled to the brain, you tend to see deficits that are maximum at onset. The most common site of a cardioembolic stroke is in that middle cerebral artery. We also want to be concerned with internal carotid artery vessel disease causing cardioembolic stroke. A third type of ischemic stroke, and this is a new classification that has been developed, and it's a new initiative by American Heart Association and the American Stroke Association, and this is a cryptogenic stroke. A cryptogenic stroke is an ischemic stroke in which the underlying cause is unknown, and it's estimated that 1 in 3 ischemic strokes are actually within this category. So you would say, well, why does it matter if you don't know what causes it? Well, because we were looking to identify whether or not we can do secondary prevention in these individuals. The most likely suspected causes of cryptogenic stroke include some of the other ones we talked about. One is atrial fib. Now, we know that in some individuals, atrial fibrillation is paroxysmal, so they aren't always in atrial fib. So they may have runs of AFib that kind of resolve on their own. So they don't have atrial fib when we see them in the hospital, but we think that's what was causing their stroke. A second likely cause is a patent foramen ovale. Remember, that's an opening in the atrial wall. It's estimated that 15 to 25% of adults still have a small opening in that atria. And then the third potential cause of cryptogenic stroke is a clotting disorder. When we think about clotting disorders, remember those things we talked about before. Factor V Leiden, an autoimmune disease that may make someone hypercoagulable. So now let's turn our attention to the other large category, which is a hemorrhagic stroke. Remember, ischemic was the vast majority of the strokes that we see, about 80% of the pathology. 20% of strokes are hemorrhagic. When we think about hemorrhagic strokes, we subdivide those into subarachnoid and intracerebral stroke, hemorrhagic stroke. With a subarachnoid hemorrhagic stroke, there has been bleeding into the space between the arachnoid membrane and the pia mater. So that's where the bleeding has occurred. In many cases, and in a vast majority of the cases, this is due to an aneurysm. When there is a rupture of an aneurysm, this increases the intracranial pressure, as well as that blood that has entered this space is an irritant. Because this blood in the space is an irritant, the blood, that irritation manifests as vasospasm. This especially occurs 7 to 14 days after the bleed. And this vasospasm is due to the influx of calcium into the vascular smooth muscle. We also know that a subarachnoid hemorrhagic stroke can be due to an arterial venous malformation rupture. This is generally an intracranial congenital abnormality, and most of these ruptures, sometimes because it's congenital, they tend to rupture in early adulthood, usually in the 20 to 40 years of age. What happens in this AVM and the AVM rupture, or the AVM itself, is blood actually becomes shunted in this malformation from the arterial to the venous system. Because in this malformation, the blood is being shunted to the venous system now is under higher pressure, and that's why it's likely to rupture. So when an AVM rupture or when an aneurysm ruptures, the most common manifestation of that is a sudden deficit with rapid progression. These are individuals who present with the worst headache they've ever had. So they have a severe headache, they may have seizure, and that rapid progression of the neurodeficit is important. A second type of hemorrhagic stroke is an intracerebral stroke. This is bleeding within the parenchyma itself, and this frequently may occur within the basal ganglia as well as the putamen. Now, once again, sudden onset is characteristic, and they have a very rapid deterioration, just as in subarachnoid. The most common etiologies of an intracerebral bleed, hemorrhagic stroke, is hypertension or an adverse event from an anticoagulant therapy. Intracerebral hemorrhagic stroke is something that you watch for very, very carefully in elders. And one of the reasons is, remember we talked in hypertension, we talked about systolic hypertension. And so this is potentially what occurs with systolic hypertension. They will have an intracerebral bleed. With the anticoagulant adverse effect, the scary thing about this is you have someone who is on warfarin therapy. And so we know that they have prolonged clotting time, prolonged clotting time. It takes longer for them to clot. So what happens then is they get what would be considered a very minor fall or a minor bump on the head, and they end up with an intracerebral bleed. So what becomes the issue then with these hemorrhagic strokes? Well, the issue also becomes that either the clot or the bleeding area expands. As that clot or the bleeding itself expands, this puts a lot of pressure on the brain tissue that is actually surrounding the rim of the clot or the bleeding area. Now, if it's a clot, then the area around that clot becomes ischemic. As a result, the intracranial pressure increases. With the increase in intracranial pressure, you see a decrease in the blood flow and an increase in cerebral edema. With the decrease in blood flow and the cerebral edema, this worsens the ischemic process with the hemorrhagic stroke. Now, last but not least, we've been talking a lot about stroke, but I also want to remind us that not all neurodeficit is stroke. We also have to think about tumor. And tumor depends on the size, or how it manifests depends on the size and the location, because that will predict the symptoms as well as the signs of tumor. Tumors are frequently, the neurologic deficit due to tumor is usually, and the symptoms are usually associated with compression and a decrease in the ability to remove waste products, as well as edema in the area. So the neurodeficit due to tumor, we look for headache, frequently frontal or occipital, regardless of the specific location, and new onset seizure. Seizure occurs in about half of the individual with a brain tumor, as well as headache, which may be frontal or occipital, regardless of exactly where the tumor is. So in this section, I know it's been a long one, but we've got a lot to think about. We have to think about underlying pathophysiology that leads to stroke: thrombus formation, atherosclerosis, vasospasm. We have to think about how stroke manifests, and it depends on where in the brain the stroke occurs. And there are several types, not only of stroke itself, but also events that may actually lead to stroke, whether it's transient or whether it's longer standing. I hope this has been helpful as we sort through some of these issues with neuro. Please let me know if you have any questions.